Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
This tape will be mainly concerned with the sequencing of a case through the laboratory procedures, showing when the case should go to the lab, how much the lab should do, and then when it should come back to the dentist for further work on the patient, and to give the reasons for why we do it this way. This case, we have already done the diagnostic workup. We have the initial study cast mounted on the articulator, and we've done occlusal analysis, occlusal adjustment, and occlusal splint. We even have our diagnostic wax-up completed. The diagnostic wax-up can be sent to the commercial laboratory, and they can do the diagnostic wax-up for you. In this case, the diagnostic wax-up is complete. We have the teeth prepared, impressions, models mounted on the articulator, and we have the case ready to send to the lab. And the first thing we want to do is to make sure we have exactly accurate models to send to the lab. In order to demand top quality laboratory work from our laboratory technicians, a case must be complete and accurate. We must have accurate dies. We have checked the accuracy of the die in the patient's mouth with our bonnets. Remember that we tried these bonnets on, made sure that these were, the die was an accurate impression or an accurate copy of the mouth. So we have at this point made sure that all of the dies are accurate copies of the tooth. The die should be trimmed properly so that the laboratory man can tell where the margin should end. The die should have a stable seat in the model. In our working cast, there should be no twisting. The die should fit very accurately in the model. You can see here we have made preparations in the base of the die, the little fingers that extend into the stone, so that when we place the die in its position, there is no twisting, tilting of the die in that position. If there was a bridge abutment, we'd be able to solder the bridge off of these die positions because they are accurate. There's no twisting or tilting. If a die twists or tilt, then it's not an accurate model. We need to mark the margins of our die. As you can see on these, we've gone around and we've marked where the margin of the restoration should be. This is a difficult thing to communicate to the laboratory technician, is where we have ended our margin. If they are going to interpret where we've ended the margin, this is where we run into trouble. The bonnet can be used to tell a laboratory technician where the margin should be, but another way to do this is to paint this margin, or where we want the margin finished, with a material that will not come off. A thing that we can use, or a pen that we can use for this, is a pen that's filled with India ink, a Sharpie's pen, a marking pen, and we can use this to go around the margin of the die, holding the pen so that it will mark those areas, and we can go right around the die and mark the area where we do not want the casting to extend. Some people would rather undercut this area so the laboratory technician cannot extend the casting into this area, but these are other variations. I would still want to mark this some way for the laboratory man to know where I want the margins. If we leave this to his individual interpretation, he might interpret a different area than we have marked on the die. If we have bridges and we're going to solder restorations together, you should at this time check the path of draw. Make sure that the restoration will draw at this time. We also needed need to send to the lab man an accurately positioned set of casts, and this we did with our centric relation registration. If you notice on this case, we have destroyed all of the teeth, all of the contact surfaces of the teeth. So that the vertical dimension can be changed if the laboratory technician changes the incisal pin. So what we want to do is to make sure with our bonnets in place, this is the vertical dimension that we want to maintain on the case, make sure that the incisal pin is contacting the centric stop, and this is locked tightly and also recorded so that this cannot change. If we take the bonnets out, the teeth will be separated. If this is changed, then we're going to change our vertical dimension. We've also destroyed any of the anterior guidance for the case. This must be set tentatively when we send it to the laboratory. So from the study cast mounted on the articulator, we have made a custom incisal guide table which gives us the guidance that we would want to start in the restoration of this case. This would be a tentative guidance to transfer over to the lingual surfaces of our anterior teeth in the wax-up. We have now got the laboratory models ready to send to the commercial laboratory, and we start the difficult procedure of trying to communicate with the dental laboratory. And this we do through the prescription to the laboratory. If we write too much, the laboratory technician doesn't have time to read all we're going to write, and yet if we don't write enough, we're going to wind up with some very sorry errors in the case. So what you want to do is to put down the pertinent information and to give the laboratory technician that information that he needs to complete this segment of the laboratory procedure. So you can see here what we're going to do is send this case to the lab now and have him return the full wax up for correction. So we only give him the information that he would need to know in order to do a complete wax up. Now we do a full wax up, anteriors and posterior teeth, because the posterior teeth are used to tell how much lingual concavity we need on the anterior teeth. So we will have a full mouth wax up by the laboratory. We would need such information as the type of wax up that you want, the long centric wax up, or the Peter K. Thomas type as this situation calls for. We want to tell the lab technician somewhat about the material we're going to use. In this case, we're going to use a porcelain fused to gold with facings on it so that he can have some idea of how this will affect his wax up. The ponic design and so on are all important information that we need to send along at this stage for the patient or for the case to go to the laboratory. Now it's also well that when the case gets to the laboratory that we go ahead and give the laboratory technician a call on the telephone and communicate directly with him. We must remember that we've got lots of hours of time, lots of money involved in this case. Now to aid the laboratory technician in aesthetics, we can send the original casts along to the laboratory, casts that we had the original case. If the anterior teeth are not too mutilated, we can use these to determine the anterior aesthetics. We would also send along the diagnostic wax-up because this information shows the laboratory technician important information about the curve of spee, the plane of occlusion, the buccal outlines and contours of the teeth. So now with this information, we can send the case to the laboratory and ask for a full mouth wax-up. When the case returns from the lab for our wax-up of the anterior and posterior teeth, You'll always check to make sure that the articulator, all the adjustments are tight. Make sure all the settings are the same as you recorded before you sent it to lab. Sometimes the setting can come loose and you'll have an erroneous setting. You also want to make sure that the vertical dimension is maintained. Check to see that the incisal pin is down on the incisal table. First of all, make sure that the setting is the setting that we sent to the lab, and then check to make sure or the incisal pin is resting on the incisal table. And then check to make sure that the wax up is in contact. Also, if the has been removed from the articulator, make sure that there is no wax or between the two. The articulator, take that off, check in between, and make sure that you have a good fit. These are all areas that cause error in the final wax up, or final occlusion. Also, it's well to take all of the eyes out of the model, make sure that there is no wax between the base of the die of the die and the stone. The die can be elevated out of the socket by flakes of wax that collect on the base of the die or the dowel pin. Make sure that this wax is all removed and you have a good accurate seat of the die back into the working model. That die has been elevated out of the working model by the wax chip and so on, then it'll be an erroneous occlusion. As you can see here, we have a full wax up of the posterior occlusion and of the anterior teeth. Now, we have a full wax up at this time because we don't know how to design the anterior guidance until we put the teeth in wax. So we get a full wax up to begin with. And at this stage of the game, we'll go ahead and refine the anterior wax up, our guidance and our contact. We'll send this back to the lab and get the anterior teeth cast and on the anterior teeth, establish the guidance we're going to have for the case before we go ahead and refine the posterior teeth. This is the completed wax up of the mandibular teeth. Now we can tell whether we've got contact or not by dusting the occlusal surfaces with the zinc stearate, which acts as a lubricant and also as a contact indicator. So we dust the occlusal surfaces with the zinc stearate, and now we can examine the occlusal details of the occlusal contacts. So placing it together a couple of times, we can tell where the contacts occur by tapping it together. Notice here we've brought the cusps into the fossa areas the best we can. We can go through our functional movements and determine where we've got contact and where we have got clearance. And then we can examine these contacts on the teeth and determine whether we have them in the right place. Now our concern, as I said, would be mainly at these ledges on the lingual surfaces of the anterior teeth. We want definite ledges for contacts with the mandibular anterior teeth, definite centric stops. As you can see here, we have ledges or definite stops for the lower anterior teeth. And from there, we have our lingual surface of the anterior teeth to act as our guidance teeth. And these ledges are very important. To determine the guidance, the laboratory technician was asked to copy the guidance that we sent on the incisal table. To see if this guidance is sufficient to clear the posterior teeth, we'd want to remove the incisal pin from the articulator so that we could check the actual guidance in the wax. Be careful not to rub these too hard or you'll wear away the guidance, but carefully check to see that the anterior teeth provide the desired guidance on the posterior teeth. Now we'd like the anterior teeth to separate the posterior teeth as we go into our working and balancing movement. So the canine rise on this side would clear out the working and balancing on the posterior teeth, and the canine on the opposite side would clear out the working and balance on the opposite side. Improtrusive, we'd want a number of anterior teeth in contact. Again, this is in wax. This will be carved away, but this will give us an idea of the guidance that we would have. Make sure that we have these stops or ledges on the anterior teeth, as you can see here. These ledges, stops on the anterior teeth. Now the guidance in the protrusive movement is very uneven here, but then again this will be corrected when we go to have the porcelain baked on the anterior teeth. So the guidance looks about right at this stage. The other thing that we'd want to check is roughly the aesthetics of the case. This is a masculine, a male individual, and we'd want certain characteristics in these teeth, as you can see here. Now we sent to the laboratory the working models of the individual's natural teeth, and this can be used as a guide as to what the natural teeth looked like. So that you can get some idea of what the natural shape was. This is helpful to the laboratory technician. We'd want a very bold masculine tooth. Also, we sent along to the lab and as a guide in the wax-up, the diagnostic wax-up of the case, and this again serves as a guide to the laboratory technician on how these anterior teeth should be waxed up, and also what can be done on the posterior teeth. We'd want to check the margins, make sure that the laboratory technician has interpreted the area where the margin should be. Remember that we blacked out the area around the die, and we should take out each one of the dies. And make sure that the margins are waxed to the margin of the die that we want for our finished casting. So check around the margins, make sure. Now there's an area where they're over-waxed. This would want to be cut back before the casting was made so that we wouldn't get a bend in the margin. So each die, each wax pattern should be checked for the accuracy of the waxing to the margins. Once we've checked the contacts, the guidance, and the margins, we're now ready to send this back to the laboratory for the completion of our anterior teeth. In this instance, I'll go ahead and cast the 6 lower anterior teeth and the 6 maxillary anterior teeth, bake the porcelain. This will give us our anterior guidance, and we'll return the case from the lab and we'll refine the posterior teeth. At this stage of the case, we would send back to the lab instructions about how we would want the porcelain, design of the porcelain area, and also the shade guide and the shade button that we would like for the teeth. The wax-up of the entire case was necessary in order to establish the anterior guidance. However, the anterior guidance is the first thing that we want to convert to the restorative material. So we want to finalize our anterior guidance before we finish the wax-up on the posterior teeth. And we will now send the case to the lab and get the anterior teeth in the final restorative material. We have the case back from the laboratory at this time. At this appointment, we want to establish our aesthetics on the restorations, verify the margins, and also establish our anterior guidance. At this point, we would like to be able to get rid of the incisal pen, adjust the incisal guidance so that in the refinement of the posterior wax-up, as you can see here, the posterior teeth are still in wax because we want to now refine our anterior guidance, make sure it's the way we want it so that the teeth will write against each other and provide the guidance before we refine the posterior wax-up. We want to make sure that the anterior guidance is designed to clear the posterior teeth out in the working and the balancing. Remembering that generally the incisal guidance from our incisal guide table is straight and the lingual surfaces of the anterior teeth will be curved. So it's important to get the anterior guidance established on the lingual surfaces of the anterior teeth at this time. We have established the centric stops in gold on the lingual surfaces of the maxillary anterior teeth for our contact. And then we have our porcelain for our aesthetics. So we want to go in here now and adjust the anterior guidance to what we want in the mouth. Now that we've got all the restorations in, the contacts adjusted, we can go ahead now and check our occlusion. First thing we'd want to establish is good centric contacts, so we would check to make sure that we've got, no, leave those in, please. Make sure we've got good contact between the teeth, close, open, close on the back teeth. Okay, we've got good contact on that one. Open, please, close. Light there, close. Open, close. Open, close. Open, close. So we're a little high on the, tight on the canines and a little bit light on each of the centrals. So we can check to see where we're contacting. Close, please. Tap, tap. Open, close. Open. Now the one contact that we have is on the distal of the canine. We want to remove that. You can see the contact that we have on this canine. Lighten the contacts to pick up a little more contact on the anterior teeth. Now we want positive contact on the canines and just barely a light contact on the centrals and laterals. Let's have a small stone. We can see the tissue relationship here. This tissue was in real good shape for having temporaries on that long, and this we attribute to temporaries that are properly designed and also a patient with good oral hygiene. Close, please. Tap, tap. Close. Just hold it. Now we just have a very light contact on the centrals and laterals. Open, please. Close. Open, close, open, close, open, close, open. Now I want you to slide from side to side slowly. Back. Now what we want here is a nice, even, smooth movement from side to side. So we want to contour, recontour, close, rub from side to side. Open, please, close, side to side. We've got the, open, please, the steepness of our incisal guidance established from the articulator in our study cast. We now want to adjust the concavity, the lingual concavity, on the restoration. As we see here, of where the guidance is coming, we're coming across the gold here into the porcelain. We have our centric stop, or our supporting stop here, and we want a nice, gentle concavity as we come out to the cusp tip. This gives us our slow guidance, or our lingual concavity for our guidance. So we will adjust that guidance so that we have a nice, smooth movement. And this is the thing you want to check in the mouth, is to see if the patient can move smoothly on these guidance areas. Should be no irregularity as it comes from porcelain to gold. Okay, close. Tap, tap. Now we still want to maintain contact. Open, please. Close. Open, close. Open, close. Open, close. Open, close. Open, close on the back. Close. Open. Open, please. Close. Open. Close. Rub from side to side again, please. Now you can put your finger against the labial surface of the canine anterior. That's a nice, smooth movement. If you feel any bumping at all in that area, then you need to reduce it some more. Close, please. Come out on your front teeth. Now we're picking up more of the rest of the anterior teeth. We'd go ahead and make the final subtle adjustments in our functional analysis. Close again. In our lateral excursions, we'd like the canines to contact only. Rub to this side, please. Nice, smooth movement. As they moved into the working and balancing movement, move the other side, please. Now out on your front teeth. And then have as many teeth in contact as we could in the protrusive movement. Now the gingival areas of these restorations are, I think, fairly good. The concavities, there's not too much bulk in this area. The teeth have the masculine characteristics. You see that the lateral is more prominent in the male. The incisal edges are more of a rugged-looking appearance, square corners. There's not much difference between the lateral incisor and the incisor length. The canines are longer and harsher. These are all male traits. You see more of the mesial surface of the lateral incisor on the male than you do the female. And these give the masculine characteristics. The return of the restorations in the biscuit bake, as you can see, gives us the opportunity to check for our aesthetics and for the contour of the restorations. We can modify this, and then we can send this back to the laboratory, and they would put the final glaze on the porcelain and also polish the axial surfaces of the anterior teeth. With the anterior guidance established in the final material, we can go ahead and establish our posterior occlusion the way that we'd want for the case. Whether we had a point-centric, a nathological Peter K. Thomas wax-up, or whether we would use a long-centric, depends on the merits of the case, and this we would go into and go ahead and do at this time. We would then send the case back to the laboratory, have them cast the posterior teeth, and give us a biscuit bake on those restorations with facings. And this would come back to us again so that we could go to the mouth, make our corrections on these restorations. Now, for following the continuity of our procedures, we've had to use two different cases in this presentation. The adjustment of the posterior restorations in the mouth will be shown on a feminine patient or a female patient. The case has been returned from the laboratory. We have had the posterior teeth cast, and we have our porcelain on these teeth in a biscuit bake. We now have the case back so that we can go to the mouth and trim the porcelain the way we'd like, so we have this in a biscuit bake. The bridge on this side will have to be soldered to the cuspid here after we do the baking or the glazing of the porcelain. If you are going to solder after the porcelain is baked, you have to wait till after we get the glaze on these before we can do the soldering. The anterior teeth we contoured the last time, and they have been glazed, so now we can go in and check in the mouth our final aesthetics. If we wanted to do any staining or characterization of these anterior teeth, we would do it at this time. But the anterior teeth we contoured last time for the feminine characteristics, and now they have been glazed. This bridge, mandibular bridge, is a unit casting. It is better to do a unit casting because if you wanted to stain or characterize this after it was glazed, you could do so because you could heat this up to melt the glaze. If you solder after you have glazed it, then you cannot characterize or stain. The porcelain, placing the porcelain on the teeth, we've modified a little bit. This is a young girl, rather nice looking, and we've tried to camouflage the show of gold. So as you see here, there was no occlusal contact in the mesial pit area of the bicuspids, so we had the laboratory technician extend the porcelain into the mesial pit area. So that as we look from an anterior view, the porcelain hides the gold in this area, and yet we have the gold for our occlusal contact, so that there isn't so much gold showing on those bicuspids. We have changed the porcelain in the maxillary crowns to camouflage the gold a little bit too. As you see here, we have extended the gold, the porcelain, over the occlusal surface so that we have porcelain cusps contacting. Now we can do this if you do not have any occlusal contact going over this margin. We have waxed the case so that it will function and clear out without contacting these porcelain areas. If you're going to have a cusp go over the porcelain gold margin, then you're going to fracture a facing. But with the proper design of the occlusion, you can carry this porcelain, as you can see, onto these cusp areas so that it will hide the show of gold. To check the castings and the work back from the laboratory, we'd want to make sure that we have maintained our centric. Check to make sure that the pin is down on the incisal table and the condyles are down on the condyle balls. To make sure that we have maintained our occlusion, you want to make sure that the dies are seated well in the master models. in the waxing procedures, a dye could collect wax under the base so that in the final occlusion we would have the dye elevated out of the master model and the occlusion would not be right. So make sure that all of the wax is off from the base of the dye. We also would check at this time the accuracy of the margins and the casting. Go around and make sure that the casting extends out to the margin that we have designated for the laboratory. Now on these posterior crowns we use a gold collar. This is more compatible with the tissue. In the anterior part of the mouth we wouldn't be able to use this because this would be obvious from the aesthetic standpoint. Now I wouldn't finish the margins down too closely at this stage of the laboratory procedure. If we were going to do a remount, you might damage the margins if you tried to thin them out too much. So we check the dies, the individual fit of the casting onto the die. Make sure that there are no irregularities inside the casting. These should all be sandblasted, and you individually adjust each casting so that it goes down on the die. Once you're assured that all of the castings are seated properly on the dies and all the dies are in their correct position in the master model, then we can verify the occlusion. We previously adjusted the anterior teeth so that they would maintain our contact. So with our shim stock, we check to make sure that we've maintained contact with our anterior teeth. Now how far we go with the occlusion at this state depends on what your plans are going to be. We can go ahead and adjust the occlusion as finely as we can on this mounting because we have done a transfer of our dies, and we can go back to the mouth with a fairly well adjusted occlusion, provided the temporaries have maintained the case. However, if the case has been in the laboratory a long time, this one has been going on 6 months in the laboratory procedures, we could have some change of the teeth, so we are going to plan almost routine in this case to do a remount of the castings. So we'd now go to the mouth, try in all of the castings, verify the accuracy of the margin, go ahead and modify the porcelain, and send it back to the laboratory for soldering of the bridges and glazing of the porcelain. Then when we get it back, we will do our remount procedures. We now place the restorations in the mouth. And the first thing that we would like to verify is the accuracies of the margins. This should be no problem, provided we verified our dies with the bonnets when we checked out the case before we sent it to the lab. But it's still a good idea to go around and check these. Then what we would like to do now is to contour the restorations and the crowns and the porcelain to give a good gingival environment here. You can see here we've got quite a bit of a bulge in this area. This one's not too bad. This contour we would like to have. The under contour is better for the gingival tissue than an over contour. So this is why we have it returned in the biscuit bake. We will take this crown now and start working down the porcelain. Improving the contour of that restoration. Can you throw a little air on there, please? In trimming the crown or contouring the crown, we want to make sure that we wind up with a concavity here on the proximal areas. Remember that we have a gingival papilla that needs to live in that area, so we would like to develop a concavity for that papilla in the area. Also, we would like to cut down any over-contour, in this mouth particularly. She has a very sensitive gingival tissue that responds to the slightest bit of plaque, so we would want to eliminate any undercuts and have as self-cleansing an area as we can. In checking the restoration, you want to make sure that it goes down all the way. Make sure that it fits the tooth the same way as it fits the die. If your temporaries haven't been keeping the tissue out of the road, then you may have to retract the tissue. You want to check your contacts to make sure that the contacts are not holding the restoration up, but you can see what we're trying to do with this contour here now is to make a nice even contour for that restoration. So we'd go back and each one of the crowns, fit it to the area, opening up the proximal area so that we can have a good area for the gingival tissue. I hope it is obvious from this presentation the role of the laboratory technician and the role of the dentist in the preparation of the laboratory material. The dentist has a responsibility for the final aesthetics of the case. They know the patient, they've seen the patient, the laboratory technician has not. So therefore the dentist should make the final corrections for aesthetics of the case. Also, the contour of the tissue is the responsibility of the dentist. The dentist can try the crowns back in the mouth, can adjust the contours of the crowns according to the gingival tissue to make it more compatible with the gingival tissue. Once we have all of the adjustments made, we would send back to the lab any soldering relations that need to be sent so that the lab can solder the bridges. Then we would have the laboratory technician go ahead, solder the bridges, glaze the porcelain facings, would polish the axial surfaces. We want the axial surfaces highly polished. The final aesthetic staining would be in the case at this stage. The case is all completed from the standpoint of the laboratory technician. The occlusal surface has been smoothened, but it comes back in a sandblasted condition so that we can now go ahead and work on the problems of the occlusion. Now, it is the dentist's responsibility to make sure that the occlusion is the way that it should be. The final adjustment of the occlusion on the articulator is the responsibility of the dentist. The laboratory technician should not do the final readjusting of the occlusion. So the case would come back to the dentist. He would make the adjustments on the articulator that are necessary, and then go to the mouth for the try-in of the case. And at that time, he would either make the decision that the occlusion was satisfactory, and he'd go ahead and cement the case in temporarily, or if the occlusion was such that it required more adjustment, then the decision to do a remount might be necessary. So you can see from this presentation that if you take an organized approach to the laboratory sequence of the case, we can go ahead and work hand in hand with the laboratory technician to provide a very satisfactory results.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.